Assalamu alaikum, everyone. We are still waiting for a few participants and panelists to join, and then we will start. Good afternoon. I'm Dr. Amber Sultan, working as a senior instructor in the Department of Surgery and Department for Educational Development. And today I'm moderating this session. I welcome you all to the Department for Educational 15th Educational Grand Round. The title of today's presentation is Clinical Supervision within Competency Framework in Postgraduate Medical Education. The format of the session is half an hour presentation by Dr. Tabassum Zehra, followed by question answer along with panel discussion. We will take questions after the presentation. So if you have any question, please use the link already shared via email and submit your questions via Google Form. I would like to introduce our speaker, Dr. Tabassum Zehra. She is an assistant professor, Department for Educational Development, Taha Khan University. Dr. Zehra has done PhD in medical education from University of Ambrosiana, Italy in 2018. Currently, Dr. Zehra holds the position of the Program Director of Masters in Health Professions Education Program. Dr. Zehra is the Chair, Academic Council, Pakistan, Academic Lead and Director of Medical Education at Medics International, a United Nations organization, accredited NGO. She leads the steering committee of medical education at Sadiq International Virtual University. I welcome you all. We have few participants from Dar es Salaam as well. So over to you, Dr. Zehra.
Thank you so much. Good morning, good afternoon, good evening from wherever you are joining. I'll just have to share my screen. Is it visible, Amber?
Yes.
Okay. Thank you so much. So today's title, as Amber has already mentioned, is related to clinical supervision. We will be talking about the competency frameworks in postgraduate medical education. And the presentation is having co-authors Dr. Oksana Zubairi and Dr. Sayeda Kausar Ali. So I have no financial or any disclosures to make. So we're going to talk about the problem statement, introduction, literature review, where we'll talk about the competence and competency-based clinical supervision, the competency frameworks, linking theories to clinical supervision, and also proposing a competency-based clinical supervision definition. Then there's a study which was conducted. I'll be talking about the rationale of the study, talk about the methodology, the results, and a model that's going to be proposed in relation to the findings and the working framework related to the model, and then final recommendations that we will propose. So clinical supervision has been known as a distinctive professional activity. It has a complexity of outcomes, and these complexity of outcomes have been cited in literature to hamper the development of a framework. And for effective clinical supervision to happen, it has to increase both supervisor and supervisees learning and their practices. So effective clinical supervision demands professional development in the required field and competence in teaching and assessing the residency outcomes. So it's related to the professional development as well. And the clinical supervisor's professional development is absolutely essential for the development of the supervisor in each of the competencies. There has been no studies reported regarding the nature and adequacy of the residents with respect to clinical supervision in literature. In this context also, AKU had an external review which was conducted in November 2012 by an international experts for all of the residency programs which are being offered by PGME. And the report, the external review report said that there's a variability in clinical supervision which is being offered in different residency programs. So the practice of clinical supervision requires the knowledge, skills, attitudes, and values needed for patient care under supervision of an expert, without mention of achievement of competency. So literature has reported a number of skills and set of competencies that are required for clinical supervision. However, the competency achievement is not being mentioned. How this has to be achieved. Competence of supervisee is related to the clinical supervision which has been provided, and it has to entrust trainees with desired responsibilities. So the dirt of faculty development in the competency framework is to provide and it has to provide adequate supervision. So in this context, with all this literature available, which is mostly from psychology and nursing, and less has been reported with respect to medical education, there's a need to develop contextual, useful, and practical clinical supervision models. So the current evolving challenge is to have an inclusive definition as well, and a consensus about competency-based clinical supervision framework to be developed, implemented, and evaluated, which is specifically related to medical education and talking about postgraduate medical education. And when we talk about different aspects of clinical supervision, there are multiple factors that have been affecting the clinical supervision practices. And this has been reported in literature, like there are factors which report mostly is the supervisor-supervisee relationship, which talks about the learning which occurs in a social context and interpersonal relationship. So the quality is affected by this relationship, and obviously self-efficacy, which motivates the learner, the residents, and also affects the programmatic outcomes. Hence, learning environment also influences the supervisory competence, and it also affects the achievement of the competencies. And the programmatic support is obviously essential to provide a conducive learning environment. And the most important is the supervisor development, where the supervisor increases the competence of the supervision being provided, and to have a better understanding of the requirements of clinical supervision. So what is competence and competency-based clinical supervision? Competence in healthcare is being defined as the professional ability, which is obviously a set of abilities required for appropriate decision making of the learner, which is in this case the resident, to provide safe and reliable healthcare in a consistent manner that yields desirable patient outcomes. Now, what is competency-based clinical supervision? Basically, it's an approach, right? So it's an approach to develop the clinical competencies through daily practice. The resident or the learner has to practice it daily in order to be proficient in that area, in order to develop that competency. And what are these competencies? Related to essential skills, knowledge, which will be technical communication, then clinical reasoning and attitudes, and obviously values and reflection. So there are many theories that are being, reported in literature that always combine and you work together to affect the clinical supervision. So as we look into the literature, the theories that are being said to report or linked to the clinical supervision are related to like Gagney's learning model, Cobb's experiential learning, Skinner's operant conditioning, and transformation learning theory. So how do all these four theories link to this model? According to Gagney's instruction model, appropriate sequence of instruction and arranged in a hierarchical order. Now, the sequence of instruction has to be, if we look into the residency training, you could see that every resident here has a different set of competencies that they have to achieve, and it's in a hierarchical order, and it occurs progressively. Then for Cobb's experiential learning, Development is achieved by higher level integration. We always integrate the knowledge as the resident progress, and it's a four-stage cycle where observation, reflection, experiences, and abstract conceptualization is there. Um, then talking about the Skinner's theory, performance is influenced by learning in different situations. Now he is talking about the contextual learning. So different situations where the learners or residents, experience and they learn from their situations. Then operant, which is the learner, is shaped by frequent exposure to the change behavior. Different settings, different situations, different behaviors. However, this theory fails to adequately explain higher order and complex form of learning. It just talks about the um, uh, does not talk about the higher order thinking and complex learning. So as the residents progress in their learning, obviously they are transforming. So it's transformation is or it's instrumental, it's task oriented. It's communicative. We talk about values, ideals, feelings, moral decisions, and obviously, as the learner progress in the learning, they become more the authoritative and more the autonomy they have in their decision making and commitment. So, talking about competency frameworks, um, there are varied frameworks of undergraduate medical education in Pakistan throughout the time of independence. However, there were no postgraduate medical education institutions in the country at the time of its independence. College of Physicians and Surgeons Pakistan was established in 1962, catering to PGME and the residency programs that it has currently. Implementation of competency-based medical education requires an organized and structured set of interrelated competencies, which is known as the competency framework. CPSP currently have a competency model, which is for the national residency programs. However, if you look at the international, there are some examples that we can look for. The first that was proposed was by CanMed. ACGME was the second, and which is the Accreditation Council for Graduate Medical Education. And the national level, we can see CPSP competency medal, and obviously now AKU also have the PGME competencies for their residency program. So this is what it looks like. Um, you can see the different outcomes and competencies that have been defined by each of these models or the frameworks that are there: medical knowledge, expert, communicator, collaborator. Previously for CanMats, it were defined as leader. Now they have, previously, sorry, it was it is known as manager. Now it's known as a leader. They have modified it to being a leader. And then advocate, professional, and scholar. So these are the competencies or outcomes that are expected out of the graduate programs, the postgraduate programs. And you can see there is overlap of all these competencies and outcomes in every of the framework that is here. However, they might not be framing it in the same way, but it is somewhere there. ACGME might not have the same work competency used as collaborator, but they use for the patient care, and then the practice-based learning and improvement. So this is somewhere, it's still not very clear, very obvious, but they are subsumed within the competencies and outcomes. AKU also follow the same competencies for the AKU graduate residency programs. PBLI, team member, systems in practice, medical expert, knowledge communicator, all have been identified for the AKU postgraduate medical education residency programs. Now, based on all this literature that we have reviewed and the competency frameworks that we have listened and we have discussed, we have observed, there's a competency based clinical supervision definition which is being proposed, which is all inclusive. And that was the main, as I said that in my earlier slide, there's a challenge of having a inductive or all inclusive definition. So what we are trying to propose is a competency based clinical supervision definition, which talks about competency based clinical supervision is a teaching strategy used to meet expected standards of competence, as we say that these are the competency levels that the resident has to achieve, defined by the program and within the competency framework, which should be according to WFME, which is the World Federation for Medical Education, basic and advanced standards. So it enhances the use of essential knowledge, skills, which may be clinical, which may be procedural, and reasoning, peer and supervisor relationships, interpersonal and communication skills, teamwork, ethical approaches, direct observations, feedback, and reflection in daily practice in order to develop clinically competent professionals, right? So we did while reviewing the literature, we did come across all of these aspects like communication skills, supervisor relationship, interpersonal approaches, direct observation, but ethical approaches, were not mentioned very clearly in literature while we talk about the supervision aspects. So there was a study conducted in 2013 within the AKU resident, and the needs of the residents were, basically sought with regards to the clinical supervision practices and the supervisory roles. Based on that study, a larger study was conducted in order to find out what are the factors that facilitate or hinder the process of clinical supervision within the competency framework. In the earlier study, all of the residents, there was an almost 80% of response, and all of the residents, unanimously said that yes, there is a need of better clinical supervision practices, and the importance of the clinical supervisor is essential for their development as a professional and as a personal, um, in their personal growth. So there needs to be a better understanding of the relationship between self-efficacy, the resident's learning environment, and the clinical supervisor competence through resident and supervisor responses, which was done through this study, and also to suggest appropriate measures for enhancing competence in supervisory practices. So this study was conducted at AKU. There was basically an observational study, and then the data collection method was done through cross-sectional survey questionnaire, where the residents and the supervisors from all clinical departments were sent a questionnaire, self-administered questionnaire, for related to their competencies. And there was also pilot testing done in order to eliminate or improve upon the items that are there for the question that were there for the questionnaire. So this study was based on the Proctor's model, when we could see that the learning environment affects the learner, self-efficacy affects the learner motivation, and then the programmatic outcomes are affected by this learner self-efficacy, and obviously faculty development is a facilitating or a hindering factor in the self-efficacy and the programmatic outcomes of the learner. And obviously it affects the clinical supervision practices. So the sampling was done with all AKU residents. All of the residency program were included in this study. Basically the clinical programs were included, and 75% of the response was expected out of the residents, which was around 337 residents. And this survey was also similar survey was sent to the faculty, and 75% was expected, which was about 187. um, then the resident questionnaire and the faculty questionnaire had some subscales. The residents were asked about the self-efficacy. They were asked about their learning environment based on a universal validated tool, FEAM, which is used for the postgraduate learning environment. And then there was also a supervisor survey questionnaire, which talked about the roles of supervisor. And the supervisors were sent a questionnaire which was related to the educational courses they have done, or they have attended, and the self-assessment of competence in relation to the supervisory practices. Now, the resident response rate that we received was overwhelming. We received like 74%, and supervisors were also reported to respond around 74%. And the reliability of both the questionnaire was more than 0.9%, 0.9 alpha. So the residents' responses, you could see here that majority of the responses that were received were from R2 and R1 level, and the least responses received were from R3, like resident level 3. So we could see here that by the response rate, the enthusiasm and the motivation with R1 and R2 is most with, rather than with R3, because they are somewhere in the middle, and they are in a position where they are not confident enough to understand the autonomy and their role with respect to supervisory practices. The level of supervisor which mostly responded this questionnaire, which was sent to the supervisor, were the assistant professors, and they are the ones who were reported to most enthusiastically being giving the responses to the questionnaire and also to the resident evaluation. Sorry. Um, then if we look at the years of experience of the supervisors, 40% of the supervisors were more than 10 years of experience, and around 30% have um, 4 to 5 years, and others were less than like 10% or 15%. uh, um, Then, if we look at the residents who were evaluated by the supervisors year-wise, so there's a majority of supervisors who have been evaluating the residents. Majority have evaluated R1s, and as you see, there is a downward arrow. There's a downward decline where you could see that R2s, R3s, and R4s are being evaluated less by the supervisors as compared to R1. Then if we talk about the opportunity to meet the trainee to discuss their performance, because this is one of the aspect of the clinical, most important aspect of the clinical supervision, that they have to have a discussion, they have to meet, they have to discuss the performance and give feedback. So with this respect, only 17% responded that yes, they had the opportunity to meet and discuss the performance with the supervisors, whereas 19% no. And in majority of the instances, this was not even documented, whether they met or not. This was not documented. And out of the 17% that said yes, you could see that the strengths were discussed for about 21%. The action plan and expectations were discussed with around 10%, and aspects requiring improvement were talked with about 20% of the residents, with only 17% having the general comments. And if we talk about the resident rating of the supervisor, the residents rated the supervisor in the professionalism very high, right? So they did understand, and they did agree that the supervisors are very much professional in their practices. However, they were not good or excellent role models. So if you could see that the response rate over here in the role modeling was only around 5%, and hence the reliability could not be achieved. So if we see the comparison, the means are, you could see the means. There's a wide gap between resident responses and the clinical supervisor responses of the items that are here, the health systems, personal issues, responsibilities, problem solving, reflective practice, clinical knowledge, sensitive issues, skill based feedback, counseling, role model, and so forth. So here you could see that the supervisors have rated themselves higher for their competencies related to supervisors, clinical supervision, and the residents, when they rate the clinical supervisors, are rating a little bit low. However, there are some areas where they are less. the means are almost similar, and they all agreed that clinical supervisor practices widen the clinical knowledge base, provide constructive feedback, improve the quality of the patient care, and makes a resident a better person. And they also agree to have one-to-one session for their uh, performance evaluation. So the striking findings of this study were that, residents mostly said that there's no collegial relationship with the clinical supervisor. They did say that yes, there was a collegial relationship between the residents, but the collegial relationship between the supervisor and the supervisee was not um, that it should be. And the clinical supervisors rated themselves higher, as we also saw that. And residents gave supervisors high scores in professionalism. Supervisors gave residents high score in professionalism for themselves as well, right? And the poor modeling by the clinical supervisors was rated by the residents, and there was a lack of faculty development that came out of this all of this striking finding. So while we're talking about all these aspects of clinical supervision and the findings that we have, so we try to develop a model, again, which is based on the Proctor's model, based on which the study was conducted. And if we see, faculty development affects the facilitating and hindering factors. Supervisors also develop themselves from novice to mastery level, as the residents themselves develop from novice to mastery level during their learning experiences. So faculty development for a supervisor to become a better and effective supervisor is equally essential as a learner to develop in their competencies. And this will affect the facilitating and the hindering factors. So it's important for the supervisor to develop and understand the roles. Conducive learning environment have to be provided. The supervisor-supervisee relationship is important for the quality of the relationship, for the quality of the supervisory practices. And obviously the contextual factors also vary, like the programmatic role and the support that has been provided to the residents. And this will also affect the programmatic expectations, like the competencies, the relationship that they have with the doctor patient, and the teamwork with the colleagues, and the interprofessional education. um, and obviously this will affect the performance and will ultimately lead to the patient care. So this when this all these factors are looked into, and when these are these are looked into, and they are being catered to, like the faculty development, the self-efficacy of the learner, the learning environment is conservative. Ultimately, this will improve the patient care, leading to the programmatic outcomes and the expectations of the program and the competencies that the residents have to achieve. Now, that was a theoretical model. So how to achieve this and implement this model? So based on certain findings of the literature, as we said, that there are certain relationship factors, and all these factors act as pillars. So what we have tried to develop is a framework of working model, which you could see that faculty development is one pillar that will lead to the relationship that the supervisor has to sign off the competencies. The second pillar is the relationship, where there's a responsibility of the supervisor to sign off the competencies in order to um, give the feedback, and in order to motivate the learner to achieve the next competency and the programmatic outcomes. So the learning environment will affect similarly, and the practices will focus on the feedback, the signing of the competencies, which are the competencies that they have to sign. So the supervisor have to develop in this area of assessment in order to sign off the competencies. Like in the patient care, there are workplace-based assessments, ward rounds for medical knowledge and clinical reasoning. There are certain tools which can be used, and the supervisor has to develop themselves in this area. MCQ development, short answer questions, SAQs, key features, similar other case-based discussions. And then for the communication skills and collaborator, there are certain tools that can be used like simulation, self-peer assessment, and for professionalism, obviously there are many tools for professionalism that can be used: multi-source feedback and assessment and simulation. Then PBLI, which is practice-based learning improvement exercises can be given, and for system-based practice, again, multi-source assessments, and for the outcome of pedagogy or educator, multi-source assessment and teaching portfolio can be used. So all of these outcomes have certain assessment tools that can be used, and the supervisors have to develop themselves in order to sign off these competencies for the residents. So the strength of the study was it added substantial knowledge to the already that is there in the literature, developing a theoretical framework model. However, this was only limited to one institution, and the recommendation that came out very strongly out of this study was that faculty development programs may be based on the frameworks that are already available. As you already saw, the outcomes that are there and the competencies that are there, the assessment tools that are linked to each of the outcomes, and where the supervisor can develop themselves in order to sign off the residents, and all of the frameworks can be easily and effectively achieved. So these are some of the references for this presentation. So I thank you all for patient listening, and if there are any questions, I'm ready to answer. Thank you.
Thank you, Dr. Tabas, for this wonderful presentation. And now we move on to the question answer along with the panel discussion. For the panel discussion, we have invited experts, Dr. Qamar Vilani, Dr. Muhammad Tariq, Dr. Rizwan Khan, Dr. Rukhsana Zubairi. I would like to introduce our panelists. Dr. Qamar Vilani is currently serving as a Distinguished University Professor Emeritus at Aga Khan University. He served AKU in various roles as it evolved as Professor Chairman of the Department of Medicine, Associate Dean for Education, and then Rector of the university. As Rector, he contributed to planning and development of academic units, particularly the AKU Examination Board, with the Program of Human Development. We also have Dr. Muhammad Tariq. Dr. Tariq is working at the Aga Khan University, Karachi, Pakistan, as an interim Associate Dean Education and interim Chair Department for Educational Development. He's Professor of Internal Medicine and practicing internist. In addition, he served as Director Postgraduate Programs within the Department of Medicine, Director Internship Program at AKU, and Program Director of Internal Medicine from 2001 to 2011. We also have Dr. Rukhsana Zubairi. She is an Associate Dean Education, ex-interim Founder Director, Center for Innovation in Medical Education. She is Director, National Residency Program, South at CPSP. She is also the member of Aspire Board, Aspire Assessment Panel, and Aspire Academy, Association of Medical Education in Europe. She is also on the editorial boards of Health Professions Education and Medical Education journals. She received the Tamghe Imtiaz for Medical Education in 2019. We also have Dr. Rizwan Khan. He's a professor of surgery. He's currently the Associate Dean PGME at AKU Karachi, as well as the Director of Fellowship Program in Gastrointestinal Surgery. I'm thankful for all the experts to take out their valuable time. And now we will take questions from the participants. The first question we received is, does practicing ethics comes under competencies?
Sorry, could you repeat the question?
Okay, so the first question we received from the participants, does practicing ethics come under competencies?
It's in my opinion, it's something which cuts across, and it's a competency which not only is is a set of abilities where the resident have to practice in a set of areas, but yes, it cuts across professionalism, it cut across in the system based practices, cuts across in their the practice based learning. So obviously this is something that is absolutely essential, and this is one thing that has to be achieved by the learner, and this is the necessity of the practice. So if it can be defined as a separate set of competency, however, in my opinion, it cuts across all of the competencies. If any
Okay.
other comment by the
Any other
expert.
comment from the panelist?
Yeah, I think I agree with Dr. Tabassum that it cuts across all the competencies, but mainly I think it is embedded into professionalism. And I think, yes, ethics is very much a part and parcel of any residency training and any supervisory training in any institution of the world. So yes, it is very, very important. It should be included. Yeah.
Yes, Dr. Zubairi. Dr.
Yes, it is actually an absolutely important part of professionalism. Just like professionalism cuts across. You see, you cannot be a professional without some adequate knowledge. You cannot be a professional in the same way. But as Dr. Muhammad Tariq said, this is an integral component of professionalism. Ethics, yes, it is a competency embedded within the larger, which I call the mega competency called professionalism.
Okay, thank you. Yes, any further comment from the panelist? Okay, so we will move on to our next question. Um, how the faculty supervisors is developed and assist, and do we have any particular program for development, for their development? Yes.
um Currently, like there's no formal kind of program where we say, okay, this is a formal program for development of the clinical supervisors, but yes, we have certain aspects of faculty development which obviously relate to their practices, and obviously like we have workshops. If we talk about only at AKU, we have workshops which are important for the faculty, and where they can use these workshops as their practices leading to clinical supervision, like providing feedback, and in assessment there are like workplace based assessment, mini CEX, and other workshops that are there. And obviously we're having our master's program as well, which also leads to the areas where the supervisors can always develop themselves in the area of assessing the residents. However, if we talk about clinical supervision, we also have workshops which are there for for the supervisors, which we are now developing into a series of workshops which will lead into, and we always will be looking into all of these areas. However, if we look at the literature, there has always been a dearth of programs which are relevant and which are contextual and which are content related or content structured programs in with respect to clinical supervision. So I would say that we don't have a structured program, but yes, there are bits and pieces of faculty capacity building workshops and courses that are there. For ATU, for larger institutions, I have no idea about that. I don't think there are in any institutions across Pakistan.
I think
Thank you. Yes.
um, yes, there are workshops and there are these masters program which may help, but I think if you look at the faculty and supervising faculty, we have at least like AKU, maybe at outside as well, we have three different level of supervisory status. One is a resident rotating with a faculty. So he's doing rounds with that faculty. He's doing outpatient clinic with that faculty. So that level of supervision would be a direct clinical supervision of that student, your resident. And then other one is a supervisor who is assigned by CPSP. So there are CPSP assigned supervisors. So what should be their role in supervising the training, or only just signing their dissertations? I think that is another aspect which need to be looked at. And the third one, at AKU at least, we have program directors and coordinators. So we have three different level of people who are supervising the trainee. One, program director coordinators, who are the overall supervisor of the residency program, and then we have the CPSP assigned supervisors, and then general faculty, which is with whom the resident is rotating. So I think we, at least at AKU, we need to work on developing a program to cater all these three. Maybe in future, Dr. Tabassum, we can work on this and we can develop a program, keeping CPSP competencies and RPGME into loop.
Yes, I agree. Yes, Dr. Yeah.
Okay, G, Dr. Zubair. Dr. Zubairi, your mic is muted.
Yes, sorry. Sometimes the word clinical supervision may not be used. But if we look at the programs, we have the introductory short course, which is mandatory for all AKU faculty. And a large part of it is clinical teaching. Clinical teaching is clinical supervision. There's a component over there on simulation-based education as well, which is also part of how you can supervise simulations when real experiences may not be present. There is also a whole component on providing feedback during that, very structured. So it may not be called clinical supervision. I think from next time we should call it clinical teaching and supervision. So it's very clear to everybody that this is a mandatory component and all clinical people, even the basic science faculty, go through it. Then we have a number of workshops, which is the clinical supervisors workshops. And then at one time, Dr. Rizwan Khan may remember that we had said that the teaching, learning, and the assessment courses, just like Dr. Tariq said, that we have three levels of people. So the teaching and learning course has a whole series on clinical teaching, workplace-based assessment, in which we invite Dr. Rizwan Khan and other PGME faculty as well to supervise as well as to examine. At one stage, we had said that the teaching and the assessment courses should be vital for those who have a responsibility towards a residency program, be they a coordinator or a director. Because then you understand that the teaching, learning, and assessment needs to be a system rather than doing it on a one-to-one basis. So there are a number of programs which are present. Maybe the word, when we announce them, a separate word called supervision may not be present, but it's very much clinical teaching is already there. Thank you.
Thank you. Thank you, Dr. Zubairi. Any further comment? And then we can move on to the next one.
I just want to add a couple of things, Dr.
Yes,
Amber, if you allow
Dr.
me.
Rizwan. Yes, yes, Dr. Rizwan.
So first of all, I think the study done by Dr. Tabassum et al. Is very important. What the study tells us is that, of course, the supervision as the residents perceive it is not sufficient. I think that's the message coming from the study, very clear message that although the supervisors may think otherwise, but the residents feel that, especially in the initial years, their supervision is suboptimal, and they want to have a better, maybe, process of teaching, learning, and assessment in the initial years. That's point number one. Number two, I think at AKU, we have a number of opportunities available for the faculty, which range from introductory short course to directed workshops to dedicated courses over a few weeks. But the question is, how many of our faculty use them?
Yes.
So while we are teaching people or training people to become a physician or a surgeon or a radiologist or a pathologist or a dental or whatever, are we really preparing people to become a good clinical teacher or a supervisor? If you ask my honest answer, my answer is yes, opportunity is there, but we are not. And if we are not, then how do we expect people to supervise the trainees adequately? I think this is the question that we need to address together, probably. Yeah, opportunities are there, and some of us may be better than the others, but what is the minimum acceptable level for a faculty to become a supervisor? And then we say, now you can go and train people. Do we have any such criteria, any cutoff? I don't think so. We have opportunities. Are we using them effectively? I think that's the question that we probably need to discuss in future. And we have thought about it. We have thought about making certain courses mandatory for program directors and clinical faculty, but unfortunately it has not really worked out in its true spirit. That's what my feeling is. So thank you.
Thank you. Yes, Dr. Zubairi.
At some stage, when we finish the questions, I think we need to, some place like Rizwan actually broke the mold to talk about the real issue. I would actually step back even further, and say, even if there are millions of faculty development programs, what is the most important thing for clinical supervision? It is for the supervisors to give time to observe the learners, to actually directly observe. If you do not want to give them time, no faculty development program on earth can help. And if you do not want to, can I just make my spiel here, because Rizwan gave me an opening. So I had this in my mind to say, nothing can work. We are here not only as doctors, but an important part of being a professional is to make sure that we teach the younger generation to look after our children. If we do not do that, we are failing in our duty. If we do not become the gatekeepers of our profession by preparing properly, by observing them, giving them feedback, nurturing them, building that relationship where they can come back to us and ask us for help when they get into problems, we are not being just to our own profession. So when we talk about faculty development, the most important thing is, how much does it really mean to each one of us? What is the minimum we are required to do? And that is, the minimum is the time. If we observe and give them feedback, they will improve even without any faculty development, but they will improve better with faculty development. Just wanted to say this. Thank you.
Thank you. Yes, Dr. Villani.
Yes. Well, thank you very much, and thank you for the invitation to be here. I thoroughly support, absolutely support what Dr. Ruxana has just said, what Dr. Rizwan Khan also said, and also Muhammad Tariq. If you just take the core of what they are saying was professionalism as a sort of a broad kind of, what shall we say, just a way of classifying what is actually required. And what we are missing in all of the formality and the structure that Tabassum has presented, and we have to be careful about what is evidence-based and on and on and on, and I accept all of that. But in the process, I think we are losing the fact that we are talking about structures, processes, mechanisms of somehow assessing that which we see. And we are far, 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 far removed from the learners and trainees' point of view. What is it that those individuals are developing themselves for? And what are the opportunities that are being provided in this particular, or in any institution? In fact, there's a learning to be had anywhere in any institution at any time. What are the drivers there? What are the motivations? And if you look at it from the viewpoint of the faculty, we assume that faculty are interested in human development. They are interested in developing the next generation of faculty, next generation of professionals. The fact of the matter is that they're not. Years and years and years ago, I realized that of a graduating class, I'm talking now about Britain, not talking about here, but in Britain, there would be about 50% of the graduating class who would say, yes, I would be interested to develop a trainee. But when they're put into a position where they are allowed, are able, are required to develop trainees, that number falls off to around less than 20%. And then if you look at the people who are actually in the faculty and whom learners look upon as role models, people from whom I've learned something, you're down to less than 10%. You're more like 5%. And as for the others who are in the positions where they are required to develop the next generation, most of the time they are busy doing their own thing. And their view is, well, the opportunities are provided, let the learners learn. Now, that is the reality. And if one is building upon that reality, a superstructure, and a superstructure, and then a microscopic component, microscopic view, indeed an electronic microscopic view of each of those elements, and say, now, which of these is important? And you're in a situation where I think we are now, is that you can't see the wood for the trees. You're just looking at all the trees, you're looking at all the leaves. You don't know what the forest really is. That's my view. Lastly, what I want to say is that this is a very, very, very important topic that you're discussing. It is hugely important, and it is hugely difficult. And it's difficult because it involves clinical service. And that brings in a complexity which we haven't really wrapped our heads around. And one of the reasons we haven't wrapped our heads around it is because it's linked to money. It's linked to the financial model. What is satisfactory? What is sufficient? What is this? What is that? What do I do? What is my expertise worth? Et cetera, et cetera, et cetera. And these are all very difficult issues. So I would say that, yes, if this is an opening into a broader discussion and a broader evaluation of what it is that's required, then I think this would be worthwhile. Otherwise, you'll continue discussing until the cows come home and you'll be no further forward.
Thank you, Dr. Villani. Let's move on to another question. How can we overcome this clinical supervision within competency in this pandemic?
Feedback, how do we overcome this
Yes.
competency? Overcome
this clinical supervision within competency in this pandemic.
Does that mean how do we
perform
cater? How do we cater? Yes. How do we cater?
Yeah. Well,
yes,
anyway, I think one of the most important things is the residents are all there. The clinical faculty is all there. So yes. I think despite the pandemic, everybody's working. All we need to do is find time to observe and give feedback. That is the first. Out of all of these, you can do everything. If you do not find time to observe, you don't do anything. But Given that all the clinical faculty there, Dr. Tariq is there, all Rizwan Khan is there every day, every one of them, they're doing their clinical work. In fact, with fewer patients sometimes, there may be a greater opportunity to teach and to supervise and to be able to observe. If you have fewer patients coming in to your direct clinic, then you have, but with the teleclinics, they can also be there. The students, the residents can be there. We're talking about residents today, not students. The residents can be there and learn. They will learn, and perhaps you can also, ask them to give advice. And then there are loads of ways of doing this. So that is one of the things that it's not for the residency learning. The pandemic is not detrimental.
Yes.
I just want to add that this is a situation where the trainees need more supervision than the usual situation, because this is the time when things may get ignored under the cover of pandemics. So the process should not stop.
I think, you're absolutely right. For me, I don't think it's the residents teaching that should be compromised. The residents are there working every day. They're with you step by step. If there are fewer patients, you have more time with your residents. So the supervision should improve rather than the other way around. It's the student supervision. That's not what we're talking of today. We're talking about residents today.
Thank you. Thank you, Dr. Rizwan and Dr. Zubairi. Let's move on to the last question. Are there any updated clinical supervision checklists there? Are there any pended clinical supervision checklist? Yes.
There are lots of rating scales to assess clinicians, clinical supervisors. Dr. Irby is famous for clinical evaluations. Even I have my CTOC published, which is student evaluation, and it can be used for residents evaluation of teaching in outpatient clinics, for the ward rounds, etc. There's a huge, and then of course the Stanford scale is also there. Lots and lots of forms for assessment of clinical teachers and the supervisor. We sometimes get mixed up. Clinical teaching is clinical supervision. The only thing it insists on is that you should be able to see the person perform and then give them feedback. That's all.
I think
There are lots of forms there. Yes, sorry, somebody else wants.
Yes, Dr. Tariq wants to add.
Just
Yes,
wanted to add that timely, essential, constructive, focused feedback is really essential. The feedback at the end of the rotation and day-to-day feedback is more important. So I think for all supervisors, I think my advice would be to provide feedback, maybe just on the history taking, on examination, simple things. I think simple feedback can be very much constructive on a day-to-day basis.
And just to add, and you do need to get the workshops done, but till you get the workshops done, there are only two things to remember in feedback. The other person is a human being. You have to remember that. And the other person is there to learn, and you're there to help them learn. So you're a supportive role. So you do not denigrate, you do not say, ye bhi nahi aata. So if you just remember, you remember these two things till you do the formal workshops on feedback, that the other person is human and the other person is there to learn, and it's your job to help them learn. And if immediately we go into the nurturing relationship that Tabassu was talking, if you have that relationship going, you can actually take the skin off your residents alone, and they won't mind, as long as they know that you are doing it for them and you care for them and you care for their development. So that is the most important thing, that we feedback with care and support. Yes.
Thank you, Dr. Zubairi. Any further comment?
Amber, just last comment,
Yes.
adding to what Dr. Zuberi has said, that yes, and what Dr. Tariq has said. In this finding, the most important and striking finding that, shocked the researchers was that, feedback was not given. And if it was given, it was not given appropriately, and majority of the cases, the feedback was not even documented whether they did receive or they did not receive. And the other thing, what really hurt was that the residents were not able to rate the supervisors as a role model. So that was very striking finding, and that really hurt. So we need to think, why is this an aspect where the residents are not able to rate the supervisors as a role model, and how we can improve in this area.
Just one point. If we ask resident that rate your supervisor, a number of times they would be thinking about CPSP supervisor, the person who is assigned as a CPSP supervisor, not the faculty with whom they are rotating. So they are actually, those faculty are also the supervisors. So I think whenever we ask these kind of questions, we need to be very clear with the residents about whom we are asking these questions. So I'm not sure exactly on what basis they responded, but this might be the case. They might have said that the supervisor we haven't seen any role model as a supervisor. That might be the case, but I'm not sure.
So it said who you rotated with.
Yeah.
It said that on the form. It
Okay.
just meant they were role models. It wasn't that they weren't, but they weren't as many as we thought. Either
Exactly.
they thought that the people were running after money, or they thought that when they talked down to the resident, there's lots of levels of role modeling. So they had written a lot of stuff. Most of it was they didn't have the time, or when they gave the feedback, it was in such a derogatory fashion that it hurt them more. So they said, this is not a good role model, that kind of stuff.
Okay, thank you. Any further comment from the panelist?
Yes, if I may say one other thing, and that is, there is also, I gather, a real fear on the part of the person being assessed as to what might be the repercussions of a sort of a less than perfect response, a bit like Trump and Pence and that lot.
I like that, but one of the things is that the faculty have to remember that they have to have integrity. And if we are not honest with our residents, they will not improve.
Yes.
But honesty doesn't mean that you hurt them or you're rude. They're two different things. You can be honest with care, and you can take them apart and say, what happened? What I would next, and then ask them, and then say, okay, so next time, what would you like to do? You prepare them for next time rather than pull them apart. And then, even if you're giving constructive feedback, they will assess you properly. But if you keep on saying that, and the other last thing, we tend to think feedback means to be corrective only. Feedback also means to say a job well done. Sometimes we forget that, That's also feedback. So, those are different kinds of things that we sometimes do, which we should do in a different fashion. That's all. And that's why the faculty development that Tabassum was talking.
Okay, thank you, Dr. Zubairi. With this, I conclude
Dr.
this
Amber, you have
session.
a hand. Sorry, you have a hand raised. I think I could see.
Okay, let me.
Dr. Mushtaq has a hand raised.
Okay, Dr. Mushtaq.
Sorry to interrupt.
No, it's okay. Yes, Dr. Mushtaq.
Thank
yes,
you for
Dr.
the opportunity. Thank you for this very good discussion. The point that I wanted to ask is, you seem to say that there is just a two-way relationship here. One, and that's between the supervisor and the trainee. What about the patient? where does that fit into the equation? Oh, especially patient outcomes. Where does that fit into this equation? Thank you.
Okay. Yes, Dr. Zubairi.
Yeah, I was just saying, in a clinical supervision, the patient is always there. When you supervise, it is going to be absolutely essential. The direct observation has to be of the learner with the patient, either taking the history or performing the examination or performing a procedure or whatever. The patient may be flat on the bed and anesthetized as well. But the supervision will still take over for procedural skills and then later on for taking consent and then post-op care and all kinds of stuff. But the most important thing in nurturing the person to grow is to make them also understand that the patient is going to be important, that patient care is one of the topmost competencies in ACGME. So without that, it won't happen. It is one of the things we prepare the residents for, absolutely. But the thing is that, but I just wanted to stress was, if you have a good relationship with the learner, then they will follow a role model. I think what Dr. Mushtaq is also saying, maybe one of the role models which the residents said we were terrible role models, was perhaps that we did not give due importance to the patients in front of the residents, which we don't do it. Neither will they. Absolutely correct, Dr. Mushtaq. The patients are central, but so is the learning environment that we make for the residents to be able to develop that kind of rapport with the patients, that kind of an environment in which they can develop and be nurtured into the profession and maybe surpass us in our own clinical areas.
Okay, thank you. Any further comment?
Just last thing,
Yes, Dr. Tabassum.
Dr. Zubairi, regarding the resident responses about role model, I would not say that they said that supervisors are terrible, but rather than they were not able to rate them as outstanding. So
Okay.
that was
All
one
right.
thing.
So anyway, it was, I'm so glad for, right. We weren't that bad either. Okay, good to know.
Exactly.
But,
Yeah.
but we
Yeah.
weren't as good as we can be. We weren't rated
Yes.
as well as we should be. Okay, thank you.
Yes. Yeah.
Okay. Okay, so we conclude this session, and I would like to thank you, Dr. Tabassum, and our expert panelists for taking their valuable time and for their valuable input. Thank you so much. Thank you all.
Thank you all. Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you. Thank you very much. And
Thank you.
nice to have Dr. Villani there as well as Dr. Mushtaq, Dr. Tariq. Rizwan, it was a pleasure having you. Thank you.
Thank you.
Okay, thank you.
Thank you so much.